Good morning one and all. Today's topic is pre-malignant lesions of the oral cavity. So contents of my presentation are definitions of pre-malignant lesion and condition and classification of pre-malignant lesions and condition, in detail description of pre-malignant lesions of the oral cavity. So pre-malignant lesions of the oral cavity are defined by WHO in 1972 as a morphologically altered tissue in which cancer is more likely to occur than its apparently normal counterpart, and precancerous condition is defined as a generalized state associated with significantly increased risk of malignancy. Coming to the classification of pre-malignant lesions and conditions, WHO in 1978 classified pre-malignant lesions and conditions as follows. Precancerous lesions, leukoplakia, erythroplakia, palatal lesions in reverse smoking are included in the pre-malignant lesions, and oral submucous fibrosis, actinic keratosis, and lichen planus, discoid lupus erythematosus, dyskeratosis congenita, Plummer-Vinson syndrome are included in the precancerous conditions. In 2005, WHO recommended the usage of the word potentially malignant lesions instead of using pre-malignant lesions and conditions, but for the ease of the students, we still follow pre-malignant lesions and conditions classification. So we'll start with leukoplakia. Leukoplakia is basically derived from a Greek word which means white patch. Sir James Paget in 1851 reported this particular entity as leukokeratosis. He observed this particular leukokeratosis in smokers, and he also denoted it as smoker's patch. Leukoplakia was first described in the second half of the 19th century by a Hungarian dermatologist Schwimmer in 1877. Coming to the definition of leukoplakia, World Health Organization defined leukoplakia as a white patch or plaque that cannot be characterized clinically or pathologically as any other lesion. First International Conference on Oral Leukoplakia, conducted in Sweden in 1984, defined leukoplakia as a white patch or plaque that cannot be characterized clinically or pathologically as any other disease except for the usage of tobacco. Coming to the epidemiology of leukoplakia, the global prevalence rate of leukoplakia varies worldwide, and it is most commonly observed in the southern East Asian countries, and the prevalence rate is 2.6. The malignant transformation of leukoplakia varies from 1 to 20% in 30 years of the time, and oral leukoplakia is mainly observed in men than women in 2:1 ratio, and most commonly observed over the age of 50 years. Coming to the etiology of oral leukoplakia, tobacco is the main etiological agent for development of oral leukoplakia, either in the form of smokeless or smoke form. Both are dangerous and both may lead to formation of leukoplakia. So the carcinogens which are present in tobacco are polycyclic aromatic hydrocarbons, and nitrosopolin, nitrosopolonium, and nitrosodicthalonamine. All these carcinogens causes mutations in the cells. So these mutations leads to hyperkeratosis in the initial stage, which is revertible, but in the later stages the mutations in the epithelial cells leads to cellular atypia and formation of dysplasia. Alcohol has no direct role, but along with the tobacco it has a synergistic effect. So it dehydrates the mucosa and facilitates the penetration of the carcinogens within the epithelial cells. Sanguinaria is a plant extract which was used in formulations of certain dental mouthwashes and toothpaste previously. And idiopathic leukoplakia. Axel et al. And Pinberg classified leukoplakia as homogeneous and non-homogeneous. Homogeneous leukoplakia is further classified as flat corrugated wrinkle, and non-homogeneous leukoplakia is classified as verrucous, nodular, ulcerated, and erythroplakia types. Coming to the clinical features of homogeneous leukoplakia. Homogeneous leukoplakia is also known as thick leukoplakia, referred to a usually well-defined white patch. The borders are very well defined. It is slightly elevated from the surface. The surface is smooth in some cases, and sometimes you may see few corrugations or fissures on the surface. On the palpation, the leukoplakia appears as smooth, thin, or sometimes gives a leathery appearance and sometimes cracked mud appearance. Coming to the non-homogeneous leukoplakia, along with the white patch, some red components are included in non-homogeneous leukoplakia. Depending upon the white component, again non-homogeneous leukoplakias are classified into nodular variety leukoplakia, verrucous leukoplakia, and proliferative verrucous leukoplakia. Nodular leukoplakia have white nodules in the lesion, and it has high malignant potential when compared to the other types of leukoplakia. In verrucous leukoplakia, finger-like projections are seen in the white patch. Proliferative verrucous leukoplakia is an extensively papillary verrucoid white plaques seen especially in old female patients, especially the mandibular anterior gingiva is most commonly involved, and it has a high malignant potential than compared to the other types of leukoplakia. If you see this part, you can see finger-like projections in the first picture, and the second picture shows proliferative verrucous leukoplakia with finger-like projections, and mandibular anterior gingiva is most commonly involved by the proliferative verrucous leukoplakia. Coming to the staging of leukoplakia, a modified classification or staging system for leukoplakia was developed by Van der Waal et al. In 2000. He described or he staged according to the size and pathology of the lesion. L indicates the size of the lesion, P indicates the pathology of the lesion. L1 indicates if the lesion is measuring less than 2 centimeters, L2 indicates leukoplakia patch ranging from 2 to 4 centimeters, and L3 leukoplakia if it is greater than 4 centimeters in size. P indicates pathology, P0 indicates no epithelial dysplasia, P1 indicates distinct epithelial dysplasia, and Px indicates dysplasia not specified in the pathology report. Based on the L and P, staging system is given. Stage 1 indicates L1 P0, stage 2 indicates L2 P0, stage 3 indicates L3 P0 or L1 L2 P1, and stage 4 L3 P1. Coming to the differential diagnosis of leukoplakia, first we can include lichen planus. Lichen planus is an autoimmune disorder where white reticular striae are seen. It is usually seen in females above the age group of 40, and you can easily notice that the reticular pattern is seen in the buccal mucosa, and it bilaterally involves the most common site is buccal mucosa, and it is not associated with tobacco habit, whereas leukoplakia is associated with tobacco habit. And the white patch which is seen in lichen planus has ill-defined borders, whereas in leukoplakia it has well-defined borders. Coming to the next differential diagnosis, white sponge nevus. It is an autosomal dominant disease where the mutations of keratin K3 and K14 proteins resulting in formation of white patch. These lesions are usually seen in adolescent age group. It is a thick white patch. It is a non-scrapable white patch, and it is not associated with tobacco, and it is non-scrapable in nature. Coming to the next differential diagnosis, that is leukedema. It is a wheel-like alteration usually seen in black people. If you stretch the mucosa, the lesion will disappear, and if you leave the mucosa, the lesion reappear in the mucosa. It is asymptomatic, not associated with tobacco. And the next one, discoid lupus erythematosus, in which erosions along with white striae are seen, but this white striae gives a brush border appearance, which is a characteristic feature of discoid lupus erythematosus. And next, hypoplastic candidiasis. It mimics leukoplakia very closely, but candidiasis is seen in debilitated patients who are under cancer chemotherapy or patients immune suppression. It is seen, and Coming to the correlation of the clinical features and histopathological features, the first area shows a normal mucosa which is pink in color, and the second one, a thin smooth leukoplakia, indicates the histopathological features of hyperkeratosis and acanthosis, and the second stage, thick fissure leukoplakia, indicates the hyperkeratosis, acanthosis and lymphocytosis, and dysplasia which is very mild, confined to the basal cells, and granular or verruciform leukoplakia indicates histopathological features of irregular hyperkeratosis, bulbous retipex, lymphocytes infiltration, and moderate to severe dysplasia is seen. Some cases acanthosis, and in very few cases candidial hyphae are also found in verruciform leukoplakia. And in erythroplakia, along with the white patches, some red areas are also seen in the clinical features. Coming to the histopathological features, irregular hyperkeratosis, bullous retipex, epithelial atrophy, lymphocytes, severe dysplasia is seen, and sometimes acanthosis and sometimes carcinoma in situ is also seen in histopathological features. Coming to the investigations, so various investigations are done to identify whether there is any dysplasia present in the leukoplakia or not, so which is very important to identify. So the first one is toluidine blue staining. Toluidine blue is a methacrylate dye which has affinity to stain acidic tissues. Acids which are commonly present in the nucleus are DNA and RNA. So whenever there is dysplasia, there will be increased nuclear cytoplasmic ratio. So the amount of the nucleus or amount of the nucleic acids are more in dysplastic features when compared to the normal cells. So this dye, when it is applied, it is taken up by the dysplastic cells when compared to the normal cells. Coming to the procedure of toluidine blue staining, it is a chairside investigation. So first we have to ask the patient to rinse the mouth thoroughly with water and apply acetic acid on the lesion for 20 seconds. So this application will dehydrate the mucosa and takes out salivary glycoproteins which are present on the lesion. After that, apply 1% of toluidine blue on the lesion for 20 seconds of the time. After that, ask the patient to rinse with water, apply acetic acid on the lesion to remove the excess stain of toluidine blue, and after that examine the lesion properly, and the areas which takes up the stain indicates the dysplasia. The advantages of toluidine blue staining is it is a chairside investigation and it helps the clinician to identify the biopsy site. And one more great advantage of using toluidine blue, it will not interfere with the routine histopathological staining. So that is the beauty of this toluidine blue staining. Coming to the sensitivity of this staining technique, there is 96% of sensitivity and specificity is 86%. The disadvantage of toluidine blue is the inflammatory cells or the ulcerated areas will take up the stains. So in that case, a second toluidine blue staining is done after 1 week of time. The next investigation is visilight. So it is a chemiluminescent light. It emits bluish white light ranging of 430 nanometers to 580 nanometers. So in this, under this light, the abnormal tissues glows differently from the normal tissues, thus making it is more visible. Through cannot necessarily tell if they are potentially cancerous or not. Normal epithelium absorbs visilight and appears dark. Abnormal epithelium reflects visilight, appears white. Whenever there is hyperkeratosis and increased nuclear cytoplasmic ratio, the light is reflected back. So the abnormal cells, the dysplastic cells will appear bright, whereas the normal cells will take up the light and appears dark. So if you see, as the increased nuclear cytoplasmic ratio, as the nucleus size is increasing, it reflects the light back. And as the keratosis increases, the light is reflected back, whereas the normal cells which have normal keratin production and the normal nuclear cellular ratio will take up the light and appear dark. You can see clearly the white lesion in the second picture. So the next investigation is well scope. It is basically depends upon the autofluorescence capacity of cells. So normal cells which have a regular cellular integrity or normal cellular integrity will reflect the light back. The apple green light, when it is focused onto the lesion, the normal cells will reflect back, but the abnormal cells which have dysplasia, which lack cellular cytoskeleton with disruption of the stromal collagen, will take up the light and appears dark. The next investigation is brush biopsy, where the brush is taken up and rubbed onto the lesion and the material is taken and transferred onto the slide and then sent for histopathological investigation. And finally, the gold standard investigation for any white lesion is biopsy. Either incisional biopsy or punch biopsy is done. Coming to the treatment or management of leukoplakia, whenever you suspect any white lesion in the oral cavity, if it is less than 1 centimeter, it's always better to do an excisional biopsy. If the lesion is more than 1 centimeter, do an incisional biopsy. If the lesion shows dysplasia, then total excision of the lesion with graft and follow up once in 6 months for 3 years. If the excision is not possible, if the lesion is involving extensive area, then lycopene 4 milligrams BID dosage or 8 milligrams OD for 3 months, capsules of antioxidants with selenium BID for 6 months, and topical bleomycin 1% volume by weight thrice a day for 15 days is given. If dysplasia is absent, then retinol A, an ointment application for 1 month is done. It is a keratinolytic agent. Whatever the excess keratin is produced on the lesion is taken out by the retinol A ointment. The advanced treatment modalities are photodynamic therapy and surgical ablation or laser ablation, surgical removal of the lesion. Photodynamic therapy, so it uses photosensitizing agents. Photosensitizing agents are injected directly into the lesion or they are directly given systemically, and they are exposed to particular light, and then it causes cellular damage and membrane lysis, protein denaturation by producing reactive oxygen species. So these are CO2 lasers. Next pre-malignant lesion is erythroplakia. WHO defined erythroplakia as any lesion of the oral mucosa that presents as bright red velvety plaque which cannot be characterized clinically or pathologically as any other lesion. It is generally accepted that oral erythroplakia is much less common than oral leukoplakia. The prevalence rate is very less, it is 0.02 to 0.1%. Coming to the clinical features of erythroplakia, it presents as a red patch, a well-defined red patch, slightly depressed from the surface because it shows atrophic epithelium. The borders are very well defined. Shear described erythroplakia as homogeneous erythroplakia, erythroplakia interspersed with white patches of leukoplakia, granular or speckled erythroplakia. Coming to the differential diagnosis of erythroplakia, erythematous lichen planus is given in the first differential diagnosis. The basic difference between erythroplakia and erythematous lichen planus, the borders of erythroplakia are very well defined, whereas erythematous lichen planus will have ill-defined borders, and lichen planus is not associated with tobacco, whereas erythroplakia is associated with tobacco habit. Erythematous candidiasis, the second one, it is usually seen in immunocompromised patients, especially patients who are using broad spectrum antibiotics for a very long time and patients who are diabetic patients. In those patients, the erythematous candidiasis is seen. The borders of erythematous candidiasis are ill-defined, whereas erythroplakia borders are well-defined. Areas of mechanical irritation, denture stomatitis, vascular lesions are also included in the differential diagnosis of erythroplakia. Vascular lesion shows blanching, whereas erythroplakia does not show blanching. Diagnosis is confirmed by biopsy. 80 to 90% of erythroplakia are histopathologically shows severe dysplasia and sometimes carcinoma in situ. Coming to the treatment of erythroplakia, in cases not showing carcinoma in situ, medical management similar to leukoplakia are advised, but once showing dysplastic changes, it is always advised to do surgical therapy for treating erythroplakia. Palatal changes in reverse smoking are also included as a pre-malignant lesion. So the etiology is high temperature of the heat of cigarette pipe chutta and carcinogens which are present in the tobacco. These are the two reasons for the development of palatal changes in reverse smoking. These lesions are especially seen in Srikakulam district where they use reverse smoking. And there are three types of clinical features. Type 1 only shows erythema. In type 2, diffuse grayish-white appearance along with wrinkles and numerous elevated papules with red punctate red centers. They indicate the inflamed minor salivary gland openings. And type 3, small papillary growth will be seen in the center of the lesion. So the first picture is showing the type 1, you can see only erythema in the palate, and the second picture shows small elevated papules indicating the minor salivary duct openings, and in the type 3 papillary growths are seen in the center of the lesion. Investigations, biopsy, and coming to the treatment, elimination of the cause is very important, and antioxidants are given to treat the patient, and patients are advised to quit the habit, and in case of type 3 surgical management is also indicated. Thank you.